We know short-chain fatty acids are important as fuel for colonocytes. They're important as a metabolic energy source. We actually know we can utilize short-chain fatty acids as an energy source. They increase absorption of sodium. They improve colonic flow. There is some evidence now in animals that the production of certain short-chain fatty acids, which comes from the fermentation of fiber by bacteria, leads to modulation of a number of GI hormones, which in turn may be part of facilitating motility of the lower GI tract. And we also know that short-chain fatty acids lower colonic pH, which in general is more desirable in pediatric patients because it does inhibit the growth of coliforms, for example. Now, none of these benefits of short-chain fatty acids happen if we are not giving bacteria food for their own substrate. However, just like bacteria act on fiber, fiber may actually act on bacteria. Next slide. In other words, the type of fiber can also determine the type of bacteria that can predominate in the GI tract. We know that if we give certain types of fibers, certain types of fermentable substrates to the intestinal flora, then these dietary substrates can modulate the predominance of certain types of species of this very complex ecosystem. Next slide. As we said earlier, the role of a balanced intestinal flora or microbiota is critical for all the reasons that are listed there, as we said before, competing with bacteria and fermentation, metabolism of bile and synthesis of vitamins. But we're paying increasingly more attention now to the modulation of immune function. Next slide. An intestinal balanced microbiota really is a simplification and probably an oversimplification of what it is that we want to do when we feed bacteria. And as I said, even though we're oversimplifying this particular slide from Glenn Gibson, on the left side, we have a number of species listed which are part of the flora of pretty much a child or any adult, including staph, including Pseudomonas and Clostridia. Now these we know are bacteria which can be pathogenic. We're not sure of all the benefits they might have because except for Clostridia, they don't tend to ferment and create large amounts of butyrate, for example. They don't synthesize a lot of vitamins, but they're there. On the right side of the slide are a few other species that, such as Eubacteria, Lactobacilli, and Bifidobacteria, that we do know help inhibit the growth of other potential pathogens. We do know they do synthesize vitamins, and we do know they're generally non-pathogenic. In other words, having this balance between some that are potentially pathogenic, but clearly others that can minimize or help balance this ecosystem is important. And that's important, and we unfortunately don't have time to go into this today, because intestinal flora is probably the best trainer for the function of gut-associated lymphoid tissue. GALT requires the bacteria to be able to react and increase and modulate its T-cell function, increase the number of lymphocytes in Peyer's patches, and increase the amount of secretory IgA. Without bacteria, our GALT does not react. The problem is that we want to make sure, whenever possible, that this stimulation of gut-associated immune tissue is done by bacteria that have less chances of being pathogenic than those that have a greater chance of being pathogenic. And just as examples, next slide, it is now clear that, for example, in patients with inflammatory bowel disease, compared to controls, their intestinal flora is different. There's a number of studies, and just showing a couple here, that indicate that lactobacilli and particularly bifidobacteria tend to be decreased in patients with Crohn's disease compared to healthy controls. Patients, or in the stool of patients with active pouchitis, for example, has less bifidobacteria and lactobacilli compared to Clostridia than controls. Next slide. Not only that, there's some evidence that there is increased amount of coliforms and Clostridia, for example, and Bacteroides in patients that have Crohn's, particularly active Crohn's disease, when compared to controls. And the same thing has been found in the biopsies of patients with inflammatory bowel disease. And again, without having time to go in this, I use these simply as examples of the fact that modulating intestinal flora by non-absorbable substances, and particularly dietary fiber, and doing this especially in patients who are sick and have gastrointestinal dysfunction, is absolutely critical. When we give elemental diets with no fiber, we're starving the bacteria in the intestine. Next slide. As we said before, our hope, or one of our objectives when we manage the diet and the luminal contents of patients with gastrointestinal dysfunction is to have a more desirable balanced intestinal microbiota. This includes, among other things, increasing relatively to others the amounts of bifidobacteria and lactobacilli for some of the reasons that we just mentioned. They lower the pH because they do produce large amounts of short-chain fatty acid. They compete with pathogens, and they can help modulate the response of gut-associated lymphoid tissue. Next slide. And this leads us to this concept of prebiotics. There are specific soluble fibers that can favor more this beneficial type of intestinal flora, such as bifidobacteria and lactobacilli, compared to other potentially less desirable intestinal flora. In other words, not only bacteria act on fiber and do a lot of good things for intestinal function, but fiber can act on bacteria in terms of being a preferable type of substrate for certain species that are more desirable than others. And we'll go to the slide that says intestinal bacteria and GI immunity. As I said before, and unfortunately we don't have a lot of time, but it'd be great to talk about this if you have any questions. Intestinal bacteria are fundamental for an adequate response of gut-associated lymphoid tissue and adequate immune function of the gut. A balanced intestinal microbiota stimulates the development of immunomucosal barrier and decreases the chances for pathogen growth. In GI disease, as we said before, intestinal flora is critical, and intestinal flora requires substrate. In people with GI disease in general, we're going to have many reasons why their intestinal flora will also be altered, and their motility will be altered. We change the diet. We put patients NPO. We put them on parenteral nutrition. We totally change their substrate because they've been getting food. Suddenly now they're getting a very different food. So people are going to have a different flora. We give them antibiotics, which drastically modulate or modify their intestinal flora. And unfortunately, not always what grows back is the most desirable type of bacteria. And of course, somebody in a hospital is in a very altered microbial environment, and their ingestion of bacteria is going to be very different than the ingestion in a standard healthy situation. What happens then is we alter bacterial populations in patients with GI disease. This leads to decreased gut trophism, decreased mucosal barrier, increased risk of infection because we have altered that balanced ecosystem that we were talking about earlier. Next slide.